Good afternoon, everybody. My name is Cesare Magnetti, and I will be presenting you a brief overview of my final year undergraduate research project, which focused on deep generative models to simulate 2D patient-specific ultrasound images in real time. First of all, why is it important to develop a patient-specific simulator? Well, firstly, it can be greatly useful for training clinicians, especially regarding case repeatability of rare conditions and anomalies. Currently, clinicians train either by scanning synthetic phantoms, which lack true physiological artifacts, or by scanning real patients under the supervision of an expert, which can be really stressful for the patient. It follows that there is a great variance when it comes to diagnosing of rare cases and conditions. Secondly, the simulator could provide an environment for automatic navigation, which will be helpful to develop, for example, a fully automated scanner which will be trained through reinforcement learning. Finally, if it will be ethically accepted, one could use the simulator for retrospective patient analysis and for data augmentation. However, current simulators are not realistic enough in producing images that look like real ultrasound images, especially regarding ultrasound artifacts. Therefore, they cannot be used for any of the previously stated points. Our proposed solution is to train 4 deep learning architecture in a patient-wise fashion, which will link the inclination and position of the ultrasound transducer to the corresponding images like shown in the picture. Note that this assumes that the fetus is relatively fixed throughout the whole process, as dealing with fetal motion will greatly increase the difficulty of the scenario. In this presentation, we will briefly overview the 4 proposed architecture. We will discuss how we validated them and the achieved results. We will also discuss future work to improve the current results. Let's start by analyzing the material used throughout the process. We used a high-end ultrasound machine to acquire more than 11,000 tracked 2D ultrasound images for phantom data and more than 15,000 tracked ultrasound images for patient data coming from a 22-week gestational age fetus. On top of that, we used more than 10,000 untracked phantom images for pre-training one of the proposed architecture. We decided to split the data into a 95 to 5% proportion in a training and validation sets. And additionally, we had a test set consisting of a phantom trajectory of approximately 2,000 tracked ultrasound images. Regarding pre-processing, we followed standard guidelines to obtain equal-sized images, and we normalized them from 0 to 1, dividing by the maximum intensity. This was done to ensure that relatively dark images, perhaps due to very high acoustic shadows, would stay relatively dark once normalized. In a similar manner, we normalized the tracker information coordinates from 0 to 1, and we converted the inclination angles to a quaternion notation to, at the same time, avoid Gibbs lock and providing normalization. With this data, we trained 4 deep learning models: a simple decoder, which directly linked the tracker information to the ultrasound image, an autoencoder, which is better believed to capture image content, and since the decoding parameters of the autoencoder are essentially the same as the parameters of the decoder, we decided to pre-train the autoencoder and then transfer its weights on the decoder architecture as an initialization step. Finally, we trained a variational autoencoder, which is believed to achieve better interpolation capabilities. We will now discuss each architecture more in detail. Starting from the decoder architecture, we can see that it is composed by 5 linear layers, which will expand the 7D tracker information to an abstract inner representation. This representation will be reshaped to matrix format, and then it will be expanded using 5 convolutional layers to obtain the output. The network will be trained minimizing the mean squared error between the original image and the simulated image. At this point, we thought about adding some extra knowledge about the relationship between the tracker information and the ultrasound image. To this end, we trained a multitask autoencoder, which consists of mirroring the previous architecture to obtain an encoder-decoder architecture, which will be trained again, minimizing the mean squared error between the simulated and original image, and also constraining the latent space to resemble the tracker information. This will allow us to only use the decoder part of the network at inference time. The total loss will then be defined as the weighted sum of the two mean squared errors, and the weighting factor k equal 1 was found to be equal to 1, yielding optimal results. At this stage, it is again worth to notice that the decoder part of the network is essentially the same as the simple decoder architecture. To this end, we pre-trained the autoencoder and we transferred its weights on a decoder-only architecture as an initialization step, and this will comprehend our third proposed architecture. Finally, we have a discrete number of locations from which to simulate ultrasound images, whereas ideally we would like to simulate them from a continuous tracker distribution. To overcome this issue, we train a variational autoencoder, which is characterized by a multivariate Gaussian latent space, which will be constrained to resemble the tracking information and to resemble a normalized Gaussian through an additional KL divergence constraint. In particular, we found that a scalar factor beta equal 10 to the power of -3 yielded the optimal results. We then validated each proposed architecture through several experiments, starting from a qualitative and quantitative assessment of image quality. We used the similarity algorithm to quantitatively assess image quality, and we used an user-rated survey by 6 experts to qualitatively assess the images. We asked 3 sonographers and 3 computational imaging engineers to rate the images, and their scores were analyzed separately because we believe each category to have different level of expertise. We can see on the bottom left an example of a survey question where the user had to rate 4 simulated images, 1 for each model, on a quality scale ranging from very low image quality to very good image quality. Note that an instruction page was given with many examples of images produced with each quality score, so that the user could familiarize with the 5-point quality scale. On top of that, they had to indicate if they were able to recognize the organs and structure portrayed in the simulations. Note that the surveys was conducted in such a way that it was impossible for the user to realize which model simulated which image, as they were randomly shuffled throughout each question. And the survey comprehended a total of 200 ultrasound images. We then measured the inference time of each architecture to ensure that they were able to perform within real-time constraints. And we tested interpolation abilities, firstly generating a synthetic hole in the data, creating an incomplete dataset, which is portrayed in the picture. We then retrained every model on this incomplete dataset and measured the performance drop inside the synthetic hole. We then also simulated images along the test trajectory to evaluate how closely each model could resemble the original trajectory. Before looking at the results of such experiments, let's look at some examples of ultrasound images simulated by each model. Starting from phantom simulations, we can see that the results are quite blurry. On the other hand, we can see that most often the portrait structures are exactly the same as the ones in the original images. This observation is really important because previous work by Hu et al. Conducted in 2017, which can be found in the references, showed that it was possible to simulate high-quality ultrasound images using adversarial spatially conditioned networks. But the main difficulty that they found was that the portrait structure were not the same in the original and simulated images, and the author acknowledged the presence of mode collapse. Our models, on the other hand, always seem to produce the correct images, even though with a lower quality. We highlighted on the right an example of what is believed to be overfitting of the autoencoders to the training data, as this architecture have twice as many parameters as the corresponding decoder. Moving on to real patient simulations, we can see a great increase in image quality. This may be due to the fact that the dataset was larger and also its samples were more densely distributed. We can see that we are able to simulate complex artifacts such as shadowing and reverberation, but this observation must be backed by the results of the experiments previously discussed. Starting from the quantitative assessment of image quality, we can see that each algorithm rated the decoder to be the best simulator, with optimal values highlighted in bold. However, on our experience, these algorithms are not an ideal measure to assess image quality, and they must be backed by the qualitative survey. On the other hand, note that the inference time obtained by each architecture is largely within real-time constraints, as each architecture is able to perform under 4 milliseconds. Moving on to the survey results, we report the rate at which scorer assessed the images as a mean assessment with a standard deviation as an error bar. We can see for the phantom results that the results are skewed towards the low image quality rating, which is definitely not optimal. Furthermore, we can see that there is a lot of variance between the scores of sonographers and engineers, with the former almost never voting each model to perform good image quality or very good image quality. Overall, on phantom data, the best performing model was found to be the decoder. Moving on to real patient results, we can see that the results are way better. The average rating is definitely increased, and there is less variance between sonographers and engineers. Furthermore, the best performing architecture was still found to be the decoder, but this time closely followed by a variational autoencoder. Moving on to the table at the bottom, we report the frequency for which each user was able to recognize the organs. We can again see that the results were particularly better for patient dataset, and that the best performing model was again the decoder, closely followed by the variational autoencoder for real patient data. We will now move on to experiments on the interpolation capabilities. We divided the results between decoders and autoencoders, as for these experiments, the two categories performed extremely similarly. Therefore, for ease of visualization, we just report these two groups. We can see that the decoders achieved the lowest absolute error, both with and without the hole, indicating that they are the best interpolators. However, the drop in performance is less localized for the autoencoders, which can mean that if we improve the baseline performance of this architecture, they could eventually be the better interpolators, but more research is needed to assert this claim. Moving on to the simulated trajectory, we can see an arbitrary example where the variational autoencoder is found to perform better than the corresponding decoders, as it achieves a less blurry interpolation, which resemble the original trajectory the most. To conclude, we proposed 4 deep learning models, all able to simulate ultrasound images under 4 milliseconds. Our results find the decoder to perform better quantitatively, but qualitatively, we showed that the variational autoencoder can perform as good as the decoder on patient data. Results on the interpolation capabilities showed that the decoder is the best interpolator, but more research should be conducted to improve the performance of the variational autoencoder. Future work will focusedly main into adding an adversarial loss term to achieve higher image quality while maintaining the reliability of our proposed models to always show the correct structures. Research has already been conducted on this topic, and we achieved very optimistic results, which we aim to publish in the near future. Furthermore, we aim to integrate the models on a real-time simulator and to find a way to deal with fetal motion. Thank you everybody for listening to this presentation. I wish you all the best and good luck with your future research.